Hello. On behalf of the American College of Osteopathic Family Physicians, the California Academy of Family Physicians, and the France Foundation, we welcome you to this program, GLP-1 receptor agonist, real-world patient care strategies for patients with type 2 diabetes. I'm Jay Schubrook, a family physician and a diabetologist and a professor in the Clinical Sciences and Community Health Department at Torrey University, California. I'm joined by my colleague.
I'm Leslie Goldstein, PharmD. I'm Associate Professor in the Department of Clinical Specialties, Division of Pharmacology at New York Institute of Technology College of Osteopathic Medicine on the Long Island campus.
Here are our learning objectives for today. After engaging in this education, learners will demonstrate and improve confidence and ability to differentiate between the available GLP-1 receptor agonists based on therapy characteristics, utilize patient preferences and available treatment guidelines to select optimal GLP-1 receptor agonists for their patients with type 2 diabetes, and implement strategies to manage potential side effects of these medications in the management of type 2 diabetes. So now we'll move on to our content and talk a little bit about GLP-1 receptor agonists. Let's start with a case. Dennis is a 52-year-old male who comes in for an evaluation of his diabetes. He's had type 2 diabetes for 6 years. He also has hypertension, dyslipidemia, and MASLD. MASLD is the new name for non-alcoholic fatty liver disease. MASLD stands for metabolically dysfunction associated steatic liver disease. Quite a mouthful. He's taking metformin 1,000 milligrams twice a day, glipizide 10 milligrams twice a day, losartan 100 milligrams daily, and atorvastatin 40 milligrams daily. And he really works hard at this. He takes his medication regularly. He sets timers on his phone so he can keep up with his schedule. And he doesn't love it, but he feels this is necessary. He's pretty frustrated. During the pandemic, he has gained 12 pounds because he's really just been at home. He's had more access to food. He's been overwhelmed with stress, and he's really been doing less activity. He also said that he stopped checking his glucose as frequently because he feels like he's just getting bad news every time he checks his glucose, and that frustrates him. Let's talk a little bit more about Dennis. You can see by his vitals that he's got a weight that puts him in the obese range with a BMI of 32.1. His blood pressure seems to be pretty well controlled today at 128/78. His A1C, which is a higher than normal A1C for him, is 9.6%. And he's got very classic diabetic dyslipidemia with low HDL and high triglycerides. We want to know what Dennis's goals are for this visit, and he says he wants a regimen that's simpler. He's tired of having to make phone alerts so he can keep up with his medicines, and he's really unhappy with weight gain. He said, it must be the metformin. Why is this causing me to gain weight? And he says because he works as a tree trimmer, he cannot have lows, and so he's got to have a treatment that he can take, he can keep up with, but it's not going to put him at risk. So when you think about Dennis, what is your hemoglobin A1C goal for this patient? So there are a lot of options for A1C goal for this patient. Again, I think, this is someone who I think is relatively young, doesn't have a lot of complications, and is motivated to be involved in his care. So I think this might set you below 7%. I think it's also important to recognize that he's got some key factors in his lifestyle that might be challenging for him. And it might be that we need to set an interim goal where he's at 9.6 to say, let's try to get to 8% first, and then we'll reassess and try to get lower. I think if you set too aggressive a goal right up front, it's going to be frustrating because it's going to take a fair amount to get him back to his target. What adjustments do you recommend in his pharmacotherapy? There are a lot of treatment options that you could do here. He's already on maximum dose metformin. He's on a relatively potent dose of an sulfonylurea, and he's pretty far from goal, right? If you're going to agree on 7%, you need a 2.6% reduction. We're always going to remember to include therapeutic lifestyle change as part of his treatment, but you're going to need something with potency. And so when I look at this, I think of, potentially a basal insulin could be an option for him. You're going to have to be considerate about hypoglycemia if you've got insulin and sulfonylurea. But a GLP-1 receptor agonist might be a really good option for him because you could get that potency with not the same risk of hypoglycemia and get the benefit for weight loss. So I think adding a GLP-1 is the most likely to get him to goal. Dr. Goldstein, you have an opinion about this?
I agree with you for all the reasons you gave, Dr. Schubrook.
So now for a knowledge check. Which of the following GLP-1 receptor agonists is dosed daily independent of food? Here's the landscape of GLP-1 receptor agonists. I think it's important for us to remember that we've had these agents for nearly 20 years. The first GLP-1 receptor agonist was approved all the way back in 2005. And you can see over this timeline that we started with an agent that was twice a day before meals. We went to once a day independent of meals with liraglutide. And now we have a bunch of once a week agents, which really can help improve durability and the patient-centeredness of dosing. I do want to highlight that there are two agents on here that are combinations. In the 2016 line, you can see that lixisenatide has been combined with insulin glargine in a fixed ratio product, as well as liraglutide and insulin degludec. These agents are slightly different. We're going to focus those on less so in this presentation, but we do have our first oral GLP-1 receptor agonist in semaglutide, but this is dosed daily and it has to be dosed very specifically on an empty stomach with a small amount of water. And then finally, while it's not a pure GLP-1 receptor agonist, we have our first twin cretin, tirzepatide, that was approved in 2022. As we think about GLP-1 receptor agonists, it's important for us to recognize that type 2 diabetes is a multi-system pathologic condition. And so if we have a dam that has 8 holes, we can't just plug one hole and think that we're going to get ahead of the disease. So we need to look at these multiple metabolic defects and find how do we address them through lifestyle or pharmacotherapy. And so most of us think about decreased insulin secretion on the top left. Our beta cells fail over time. But we also know that the pancreas secretes through the islet cells too much glucagon, which raises that fasting glucose. That also contributes to an increase in hepatic glucose production down at the liver. We know that there's an abnormal satiety signal, so there's a neurotransmitter dysfunction at the brain. And even if you do get glucose and insulin to the external tissues, you may not have the optimal glucose uptake into muscles. And we've recently focused on the role of the kidney, not only as a generator of glucose, but more importantly, a maintainer of hyperglycemia through increased glucose absorption. And then it's important to recognize that fat metabolism is closely tied to glucose metabolism. And so increased lipolysis is a contributor as well. And we're going to spend a lot of time talking about the incretin effect today, which is the top middle, and the GLP-1 receptor agonists and their effects across this spectrum. So as you look at the role of GLP-1 receptor agonists in addressing the ominous octet, you can see that more than half are covered by GLP-1 receptor agonists. Let's start on the top left with the pancreas, which really has two factors. There's an increase in secretion of insulin from the beta cell, and there's also a suppression of glucagon from the alpha cell. This ends up having a net result of changing the increased hepatic glucose production at the liver. And we see that you also have beneficial at the brain from neurotransmitter effects, improving the satiety signal. All of this being run through the incretin effect at the top, which is the main mechanism of action for GLP-1 receptor agonists. And this is, again, a couple different ways to show you the GLP-1 receptor agonists. I want to highlight to you that you're not going to know all of these medicines right at the end of it. In addition to this program, we have a wonderful clinical companion guide that is a downloadable resource that will have much of this information that you can take with you and put into use into your practice. So we've got the different GLP-1 receptor agonists here. We've got the dose range. And what I want you to know from this is that across all of the GLP-1 receptor agonists, you can count on a combination of weight reduction and potent hemoglobin A1C reduction. So for this patient, this might be a really great option as part of his treatment plan. Not only are they across the board effective and beneficial for weight, I think that the dosing schedules and the dosing mechanisms are such that they really provide individualization of our patient care. You can provide an agent such as exenatide twice a day with meals that really focuses on postprandial hyperglycemia only. But now you have longer acting ones from liraglutide all the way down that will be dosed either daily or weekly. but come in either a multi-use pen or a single-use pen or even an auto-injector. And it allows you then to say which tool is going to be comfortable for your patient and which schedule is going to work with your patient. I would be remiss not to say that these agents are generally expensive. And so it's also to make sure what things are covered for your patient. So again, knowing all these choices allows you to really individualize your treatment choice for your patient. So let's go back to that knowledge check. Which of the following GLP-1 receptor agonists is dosed daily independent of food? So when you look at these answers, all of these are GLP-1 receptor agonists, but only liraglutide, which is dosed subcutaneously, is given once a day, and it is given independent of the dosing schedule with food. It can be given any time of the day. Dulaglutide and semaglutide subcutaneous are given weekly. There is an oral semaglutide that's given daily, but it has to be given on an empty stomach with a small amount of water. So again, it would not be independent of food. It has to be kind of scheduled very specifically. And exenatide comes in a twice daily given right before meals and a once weekly. So the answer is liraglutide. So there are a lot of different guidelines available today for diabetes. We want to know which of the following guidelines do you use when you're treating your patients with type 2 diabetes? And you can select all that apply. And we bring these guidelines for you for your reference so that you have easy access to them. And again, I think it's important to recognize that you'll choose the guideline that matches not only your patient location and setting, but also individualized to your patients. So we're going to talk about a couple of the different guidelines. This is the new and simplified ADA algorithm. And I don't know about you, when I look at this, it doesn't seem to be very simple to me. But I want to highlight a couple things here. When you look at this algorithm, you really could split it into the left-hand side and the right-hand side. And you see that vertical line going up, splitting it. If your patients have compelling indications, such as atherosclerotic cardiovascular disease, you would use a GLP-1 with proven cardiovascular benefit in that situation. If you have a patient that's got chronic kidney disease, we know that this is important because you could use an SGLT2 or a GLP-1 receptor agonist with proven benefit to help those patients. And I want to highlight on the left-hand side, these are given independent of the hemoglobin A1C. So you're using them as target complication-specific treatments above and beyond glucose. Not all of our patients have a complication. So if we go to the right-hand side of the equation, and we're seeing where GLP-1 receptor agonists are recommended by the ADA, you can see that when you're looking at the first column on the right, glycemic management, choose the treatment based on efficacy. You can see that when we're looking at very high and high efficacy, dulaglutide, semaglutide, and tirzepatide all have high efficacy and are recommended as treatment recommendations. And then if you look at the focus on weight, and weight has become a primary focus in the management of type 2 diabetes, again, you can see that GLP-1 receptor agonists are mentioned specifically as preferred agents for those patients. And I don't know how many people look at the ACE guidelines in the primary care setting, but I think they've done something quite unique in 2023. And I want to highlight that there are an algorithm that's glucose-centric. So if you're really trying to focus on lowering the glucose or things that are related to lowering the glucose, you would use this algorithm. So you can see here, if you looked at the columns with the red boxes, if a patient was overweight or obese, you might choose a GLP-1 receptor agonist as one of your first treatments. If a person has a high risk of hypoglycemia, again, this would be a great option for you. And if someone has significant hyperglycemia and you need something with strong efficacy, you can see that basal insulin or a GLP-1 receptor agonist or a twin incretin are recommended. So across the different guidelines, GLP-1 receptor agonists are taking a prominent role in all of the different categories because of their safety and their efficacy. So let's go back to Dennis. Dennis is again that 52-year-old male who presents for a routine evaluation of his type 2 diabetes. He has an A1C of 9.6%, and he was really on the max effective dose of metformin and glipizide. He wanted a simpler regimen. He didn't want to have to keep setting phone alerts to take his medicine. He was unhappy with weight gain, and he said he could not have hypoglycemia because of his occupation. We need that 2% decline in A1C. We want weight loss, and we need to avoid hypoglycemia. This would make a GLP-1 particularly a weekly agent, really quite optimal for his care because it would simplify and meet his goals. Now, I think it's important to recognize that if we're going to do this, he's got an agent that could cause hypoglycemia with his glipizide. So we're going to need to have a strategy where as we bring on the GLP-1 receptor agonist, we might have to decrease the sulfonylurea. And again, I think at an A1C of 9.6, I might overlap them initially, but eventually you might need to think about backing that off. And then I think it also highlights that this kind of treatment would be consistent with both the ADA and the ACE guidelines, because we're meeting not only the efficacy goals, but we're also meeting the extra-glycemic benefits. ACE also has a complication-centered algorithm. Our patient didn't have those complications, but I think it's important to recognize them. So if you look at the complication-centric algorithm, again, in the red boxes, if a patient has atherosclerotic cardiovascular disease or is at high risk, a GLP-1 receptor agonist is an excellent agent to consider, or an SGLT2. If a patient has had a history of stroke, this is a new column, a GLP-1 receptor agonist or pioglitazone can be an excellent agent to prevent secondary stroke. And then finally, those patients with CKD, choosing an agent such as an SGLT2 inhibitor or a GLP-1 receptor agonist would be a preferred agent based upon the complication, not the glucose alone.
Dr. Shubrook, what if the patient said that both his sisters had thyroid problems? One is hypothyroid and the other one has Graves' disease. How would this change your treatment plan?
Thank you, Dr. Goldstein. This is a great question and certainly quite a common question. Thank you for doing the extra work to find out what those thyroid conditions were. Because again, we do have a warning with GLP-1 receptor agonists with medullary thyroid cancer. So if they had that problem, we would be concerned. But we really have no concern about hypothyroidism and Graves' disease as it relates to the use of GLP-1s. So when I look down here, this would not necessarily change my treatment plan because there's no contraindications and no warnings for this. We don't need blood tests for these conditions. There again, the relationship is due to a rare autosomal cancer, and I don't need to get thyroid ultrasounds or avoid the class. What are your thoughts, Dr. Goldstein?
Those are certainly the recommendations. There has been no association of thyroid cancer or other thyroid problems other than MEN2.
Yeah, and that's a good point. So that's multiple endocrine neoplasia type 2. Again, an autosomal dominant condition associated with medullary thyroid cancer.
Dr. Shubrook, what if your patient were a female of reproductive age? How would this change your treatment plan?
Yeah, these are really good questions. So again, we're seeing more and more young people developing type 2 diabetes. And so we have more and more women who are of reproductive age who have developed diabetes, and we need effective treatments. We don't have any real long-term safety data with the GLP-1 receptor agonists in pregnancy. So I think if you're going to use these agents, and I do routinely in people who are of reproductive age, you need to have a family planning plan. So there needs to be some effective birth control. And ideally, you need to know how long your GLP-1 receptor agonist works before you start to do family planning if there is a desired pregnancy. So I have not personally avoided the GLP-1 receptor agonist class. I might consider changing to basal insulin if the person says they want to have a family in the next 6 to 12 months, because again, I don't want to take that risk. You certainly could have changed the GLP-1 receptor agonist to a DPP-4 inhibitor, but that would have not been nearly as efficacious. Even though it's category B, we don't use DPP-4 inhibitors commonly in pregnancy. So I guess I'm looking at potentially either changing the basal insulin if the person was going to be pregnant or want to be pregnant in the next 6 to 12 months, or if we have an acceptable birth control plan, we would use the GLP-1 receptor agonist to help the patient get under what we think is good metabolic control or meeting their targets before they start planning a pregnancy.
So, in conclusion, really, it's a matter of having a conversation with the patient and seeing what this person's goals are. Would it be possible to start with a GLP-1 receptor agonist and possibly down the road switch over to an insulin therapy?
Absolutely. What a wonderful point. Because again, it's not an absolute, right? We need to work with the patient where they are in their life and adjust as they go. And wouldn't that be great if we could get them under control with the GLP-1 and then see if they need insulin when it's time to get pregnant? So let's highlight some clinical pearls as it relates to using GLP-1 receptor agonists in type 2 diabetes. So I think one thing I want to make sure you leave with is that GLP-1 receptor agonists do glucose-dependent insulin secretion. They work as hard as they need to work, but they're not typically going to drop you low by themselves. They're very potent. And they have extra glycemic benefits, such as lowering the glucose, a slight reduction in blood pressure, but also lowering the weight, which is quite unique in medicines for diabetes. I also want to highlight that the ADA recognizes that GLP-1 receptor agonists are probably a better choice, particularly in primary care, than insulin when you're trying to do meal coverage, and really might even be a better first choice than a basal insulin because of these extra glycemic benefits and potential indications for complications. So I think it's important for us to recognize that when you're thinking about injectable therapy or a therapy such as insulin, you should also be thinking about a GLP-1 receptor agonist, whether it's injectable or oral. If you are going to give an injection, I think, again, many people are not comfortable with this. And I think showing them the first injection in the office gets over many of the fears that people have. Is there going to be pain? Can I do this? Is my glucose going to drop suddenly? So again, doing that in the office really makes a big difference to set the person off on a good first step. Now, GLP-1 receptor agonists, we're going to talk later about side effects, but I think it's important to recognize that these are expensive and these are agents that you're going to use if the patient has coverage. And so it's important to recognize that you might need to be flexible on what agent you use based upon what their coverage is.
So, audience, what is your opinion about managing adolescents with type 2 diabetes?
So we're not going to spend a lot of time about type 2 diabetes in adolescents, but I think it's important to recognize in primary care that this is becoming increasingly common. So if you look at the left-hand side of the graph, you can see that rates of type 1 diabetes are increasing, and they're going to be increasing even more since COVID. So you're going to see some changes there. But I want to highlight that we've really seen for a while a significant increase in the rates of type 2 diabetes in our adolescents, particularly in our Black, non-Hispanic, and our Hispanic populations. But we're seeing that across many populations. And you're going to want to be comfortable seeing our patients who have type 2 diabetes because this is becoming much more common. And when we look at our patients with type 2 diabetes who are adolescents or young adults, we know that this can be a much more aggressive and progressive condition. And so we don't want to be kind of more gentle in our management. We need to kind of think of time as not our friend. And I've already highlighted that we're going to see more women of reproductive age and even in pregnancy who have type 2 diabetes. And we need to recognize that that's different than gestational diabetes and give the priority to making sure that we treat early, we treat aggressively, so these young adults can grow up healthy and our women who are pregnant can have healthy babies and healthy pregnancies. It's also important to recognize that, we often think of insulin as the only treatment in pregnancy, and it is, and it's going to continue to be the best treatment in pregnancy. But we only had insulin and metformin in our children, and now we actually have GLP-1 receptor agonists that have been indicated for the treatment of adolescents with type 2 diabetes, and these could be real game changers. So I think it's important to recognize that we have tools to help these at-risk populations. So what are the key takeaways? We know that GLP-1 receptor agonists address multiple components of the pathophysiologic pathway of type 2 diabetes. We know that several of the GLP-1 receptor agonists are available to treat and individualize our patients to get them to goal. And we have guidelines and algorithms that really help us to make treatment choices for our patients or work with them. And we can treat not only the glucose, but also have extra glycemic and even complication specific treatments. And GLP-1s are going to be involved in multiple of those selections. Now we'll move on to part 2, keys to initiating GLP-1 receptor agonists. So now let's talk to Denise. Denise is Dennis's sister. She's 55 years old, and she presents for a routine evaluation for her diabetes. She's had type 2 diabetes for 12 years. She has, again, hypertension, dyslipidemia, but she also has chronic kidney disease. She's had Hashimoto's thyroiditis, and she's had a myocardial infarction 2 years ago. You can see that her treatment's a little bit more complex. She's on insulin glargine 60 units daily, sitagliptin 25 milligrams daily, losartan 100 milligrams daily, atorvastatin 40 milligrams daily. She takes a daily aspirin, and she's also taken metoprolol tartrate 100 milligrams twice a day. She's tried metformin multiple times, but gets sick every time she gets above 500 milligrams, and she does not want to take that medicine again. She's been managing her glucose with finger checks, and you can see that her fasting glucose is anywhere between 72 and 140, with a mean of 128. And after meals, she's around 140 to 228, with a little bit higher mean around 206. When you look at Denise's vital signs, you notice that her BMI is in the obese range at 32.1. Her A1C is elevated at 8.6. Her lipids are at goal, but it's important to recognize that both of her kidney function are abnormal. She's got an eGFR at 40 ml per minute, and her UACR, or albuminuria, is at 206 milligrams per gram. We asked what Denise's goals are, and she wants to feel like she can be in control again. She feels like she takes a lot of meds and thinks she's not getting to goal. She doesn't really understand what these pills are doing. It seems like we just keep adding pills. And she said, look, once I thought I went on insulin, I thought things were going to get better. She doesn't want to add medication. In fact, she'd like to know which of these can be stopped. And she's relatively young, despite the fact that she's had multiple comorbidities. She said she'd like to get her A1C down, but she's not sure how far down she should go. So we talked with her and we set a shared goal between a 7.5 and 8% A1C. So knowledge check. What adjustment do you recommend for our pharmacotherapy? So we're going to go back to that ADA algorithm and think about what are the goals for this treatment. So Denise has atherosclerotic cardiovascular disease because she's had an MI 2 years ago. So if we go to the far left of this algorithm and we go down to the history of atherosclerotic cardiovascular disease, you can see that a GLP-1 with proven cardiovascular benefit would be a recommendation regardless of her A1C. In addition to that, she's got chronic kidney disease. So we know that with chronic kidney disease, we need to be thinking about medications that would be beneficial for her. So if we highlight that section, you can see that an SGLT2 inhibitor or a GLP-1 receptor agonist with proven benefit would be, again, a treatment consideration for her, regardless of her A1C. When we go to the ACE complication-centric algorithm, again, we can highlight the same type of things. You can see that on the yellow on the left, if she's had atherosclerotic cardiovascular disease, please consider using a GLP-1 receptor agonist or an SGLT2 inhibitor. If we go to the far right in the red, if she's got chronic kidney disease, please consider an SGLT2 inhibitor or a GLP-1 receptor agonist. So you can see here that there's some uniformity and consistency in the treatment recommendations based on this patient profile. Going back to that slide that's in your clinical companion, you can again see all these things put together where you've got the different GLP-1 receptor agonists, the dose range, the A1C reduction. You have to know the A1C goal to know what reduction you're going to need. So you can see the changes in weight and then the frequency of use. So again, she's not super excited about adding medications. So we're going to have to think about what adjustment we can make. And I want to highlight here what is known and what is upcoming about GLP-1 receptor agonists. First, let's start with the blue arrows. We know that there are 3 GLP-1 receptor agonists who have met superiority compared to other treatments in the reduction of cardiovascular disease. So that 3-point MACE would be non-fatal MI, non-fatal stroke, and cardiovascular death. And you can see that liraglutide, dulaglutide, and semaglutide subcutaneous all met that 3-point MACE and have a FDA indication for that reason. We do have evidence through studies that 2 of the agents have reduced stroke. All of the agents in the GLP-1 receptor agonist that actually measured kidney outcomes saw a benefit with the use of GLP-1 receptor agonists. And while there's no FDA indication yet, I imagine someday that might come. And then going back to that metabolically dysfunction-associated steatohepatitis, or MASH, which used to be NASH, you can see 2 of the agents have shown benefit in studies for that. Again, no FDA indication. And kind of projecting to the future, we actually are starting to see studies in GLP-1 receptor agonists that are improving cognition and may affect neurocognitive disorders. We're not ready for prime time yet, but I think it's important to highlight these agents have many extra-glycemic effects. If you're worried about the safety of GLP-1 receptor agonists and the efficacy, you can see that when you put all these studies together in this meta-analysis and systematic review, you can get a statistically significant reduction in 3-point MACE, cardiovascular mortality, and all-cause mortality when you use a GLP-1 receptor agonist, as well as the renal benefit. So you can see these are all statistically significant. When you look at safety, you can see that when you put all the studies together, there was no signal for an increase in any type of thyroid cancer, let alone medullary thyroid cancer. There was a numerical increase in pancreatitis that was not statistically significant. There was a numeric reduction in pancreatic cancer, not statistically significant. And there wasn't even an increase in retinopathy. And again, I think it is important to recognize that GLP-1 receptor agonists are potent agents. And if you drop the glucose too fast, that can destabilize retinopathy. But these agents alone are not a danger to retinopathy. So let's summarize Denise. She comes in for a routine evaluation. She has a more complex history than her brother with a longer duration of diabetes, multiple other metabolic conditions, but she also has CKD and cardiovascular disease. She's on multiple agents and she feels the pressure of being on too many agents, and she wants to find something where she can feel like she's in control again. Of note, her BMI is above the target in the obese range. She's got an EGFR, which would be a class G3B, and her UACR would be a class 2, 206 milligrams per gram. So we got to find a way to get that 1.6 A1C reduction, but also be mindful of the medication burden and her comorbid conditions. So let's go back to that knowledge check. What adjustment do you recommend for her pharmacotherapy? So this is a challenging question, right? There's a lot that needs to happen here. I think I need to be careful. If you looked at her glucose readings, she had morning readings as low as 72. So again, increasing the basal insulin might lower her glucose, but could put her at risk for hypoglycemia. She was on a low dose of a DPP-4 inhibitor, probably lower than she needed to be based on her renal function. But again, that's not likely to have much benefit. You certainly could add a GLP-1 receptor agonist, but this is going to be important for her to know what is she going to be able to get rid of because she doesn't want to add medicines. You certainly could add an SGLT2 inhibitor, and that's probably going to help with some of the compelling indications, but you're not likely to get much glucose benefit at that EGFR. So that may be a less accurate choice. And then please do Denise a favor, don't restart metformin. She has tried this multiple times, and that's probably not going to be a therapeutic adjustment. So for here, I think the GLP-1 receptor agonist, with the assumption that we're going to make other medication changes, would be your best answer. When you're looking at starting your patient with the GLP-1 receptor agonist, there is no special testing you need to do. You take a history, you do a physical. Make sure they haven't had a history of pancreatitis, ask if they've had a history of gastroparesis, and make sure they don't have this autosomal dominant condition called medullary thyroid cancer or MEN2. If those things are not present and you do a physical exam and you don't feel an abnormality on the thyroid, that's all you need to do for assessing or monitoring a patient for GLP-1. I do think it's important for you to talk with your patient about what to expect, what the dosing regimens are like, and how you're going to titrate these, and make sure you provide them with a strategy of how they're going to be able to regulate other medications and not have hypoglycemia and feel like they're reducing the burden. This is a wonderful time to also get them back to diabetes education and support or a dietitian, because they will have a change in their eating habit, which is going to be therapeutic. And if they have good strategies, if you're not comfortable talking with them, having them see a dietitian can really be very beneficial. Now, if your patient wants to know, it's wonderful to share with them how these medicines work. Some patients really want to understand how they work. Other patients want to know what effects they have on them. So you can talk about the loss of normal hunger and satiety in type 2 diabetes. It's going to return with a GLP-1. They're going to need to make modifications to their diet. You can also say, even though this class of agents doesn't have hypoglycemia associated with it, if they're on insulin or a sulfonylurea, we're going to have to be careful to reduce those medicines as we increase the GLP-1. And we're going to talk quite a bit more about side effects, but these agents do have some side effects, and we want to make sure we know patients what to expect, how to handle them, and when to call us when they need extra help. So when we summarize Denise, Again, she came in, she has this complicated history. You ended up stopping the DPP-4 inhibitor because it really was underdosed and it wasn't doing much. And you gave her a once weekly GLP-1. Now, she was a little bit suspicious first, like you just traded medicines, you didn't reduce my medicine. But what we did is we took a pill a day away and we gave you a once a week injection. This, by the way, is going to also help you lose weight. And she in fact, did lose 6 pounds. And we're going to be able to reduce your insulin once we get started to a higher dose. In fact, she was quite happy we were able to reduce her insulin down to 30 units because at one point she wasn't sure how strong this would be. She was having some hypoglycemia. So we worked with her to reduce her insulin. So she's actually on less insulin, which can be a really rewarding thing for a patient, help with weight loss, and allows her now to feel like she's in control and reduce the risk, but also get targeted therapy based on her complications.
Dr. Shubrook, Denise reports that she's unwilling to take any additional injections, and she says she has too many medications. So how can we help her?
Yeah. So again, she started saying that she felt like she had too many meds to start with. So again, the beauty for this is that we do have an oral GLP-1 receptor agonist, and this would be, again, one of her options. You're still going to get that potency. You're still going to get that low risk of hypoglycemia. She will need to take it daily, but we will be able to replace the DPP-4 inhibitor with the GLP-1 receptor agonist. And I really do hope that by doing this, we'll also be able to reduce the basal insulin dose over time. This will take some time because the titration schedule is a monthly titration schedule for the oral agent, but it is still a really nice option for her if she would prefer to take an oral agent. She did indeed choose to take oral semaglutide. She went 3 milligrams for the first month. Then she went up to 7 milligrams daily, then eventually up to 14 milligrams. And again, we had to highlight that she needs to take this on an empty stomach with just a little bit of water. But she actually felt better because she said, you know what? I'm so happy I'm taking less injections. I'm happy that I got rid of one of those other pills that didn't seem to be doing much. And I'm also on less insulin and I'm losing weight.
The patient is on maximum dose of the GLP-1 receptor agonist weekly and basal insulin 60 units per day, but now has some overnight hypoglycemia. How can we modify the treatment for this patient?
Yeah, this is a really great and common question. So I think it's important to recognize as you start to get up on the higher doses of GLP-1 receptor agonists, they're very potent agents and they are glucose dependent insulin secretagogues. So you need to make room for them to work. And so as you start to get to higher doses, this is a great time to start withdrawing other therapies that are unnecessary or increase the risk of hypoglycemia. So I don't necessarily want her to eat to prevent lows. That is contradictory to what our overall goals are. But for sure, we should be able to reduce the dose of basal insulin to allow that GLP-1 to work and get the benefit. Now, many patients will think that this is the GLP-1 causing them to drop low because that's the latest agent to be added. But really, this is the time to highlight we're now working more with your own body's insulin, and we need to give you less exogenous insulin. So I don't feel like we're quite ready to stop the basal insulin or stop the GLP-1 or even reduce the GLP-1, but we can reduce the dose of basal insulin and continue to do so she can get to her glucose goals and not have hypoglycemia. Dr. Goldstein, you have thoughts about this?
That is the approach that I think would be best for this particular patient. Yes, I agree.
So what are our key takeaways? GLP-1 receptor agonists have been available since 2005. We have 20 years of experience with these agents. We have multiple different routes of administration, multiple different dosing schedules, and even different injection tools. We have oral and injectable GLP-1s, which really allows us to individualize our therapy for our patients. We also know they can be expensive, and we're able to use the one that's going to be covered. You could add a GLP-1 receptor agonist to almost any other class of medications, except for DPP-4 inhibitors. They work in the same pathway. You don't need to use them together. However, if you're going to use a GLP-1 receptor agonist on top of basal insulin, mealtime insulin, or sulfonylureas, you'll want to have a strategy to reduce or stop those agents, particularly mealtime insulin or sulfonylureas, or plan to reduce basal insulin as you start to up-titrate your GLP-1 receptor agonist.
We're going to move now to managing patients on the GLP-1 receptor agonists. Let's go back to Dennis, our 52-year-old tree trimmer who presents for a routine evaluation for his diabetes therapy. He started high-dose weekly GLP-1 receptor agonist 3 weeks ago. He complains of diarrhea for the last 2 weeks since he started taking the 2 milligram weekly dose of the GLP-1 receptor agonist. He tells us that he drinks a liter of sports drink with electrolytes daily in order to prevent dehydration, he says. He denies abdominal pain and nausea. His medications now are the metformin 1,000 milligrams twice daily, semaglutide 2 milligrams subcutaneously every week, losartan 100 milligrams daily, and atorvastatin 40 milligrams daily. He takes his medications regularly. He is as disciplined as before. He has lost 7 kilograms, which is 15.4 pounds, since beginning the GLP-1 receptor agonist 18 weeks ago. He has been titrated up over time to this 2 milligram dose. His blood pressure is still within acceptable range, and his hemoglobin A1C is now 8.2%. His lipids are at goal. Knowledge question. In addition to short-term therapy with an OTC antimotility agent, what do you recommend for managing our patients' type 2 diabetes and treatment-related side effects? The most common adverse reactions with the GLP-1 receptor agonists are nausea, vomiting, diarrhea, and constipation can also occur, particularly in the beginning of therapy, and then it sometimes converts over to diarrhea. Contraindications are medullary thyroid cancer. This is a contraindication for the entire group. Acute pancreatitis or history of pancreatitis or pancreatic cancer. Exenatide and lixisenatide are renally excreted, so we need to be thinking about the renal function when these agents are used. And worsening of gastroparesis can occur. So patients who have a history of gastroparesis or present with gastroparesis should not be receiving these drugs. In terms of use during pregnancy, they are not recommended for pregnant patients or patients planning to become pregnant. There is no long-term safety data in this patient population. And of course, as with any drug, hypersensitivity to the drug or any component of the formulation, these patients should not receive these drugs. Dr. Shubrick, which side effects have you found are impacting your patients the most?
Yeah, so I think it's important to recognize that these agents have a profound effect on appetite and satiety. So I think often people are surprised how much less they're eating. And so we really highlight that you want to be mindful when you're eating. If you overeat, you will feel sick. I'm also kind of surprised that the GLP-1 receptor agonists seem to have different side effects based upon each agent. So you can't necessarily promise that if you have a side effect of one, you'll have the same side effect in the next one.
And what strategies have you and your patients found to be most effective for managing side effects of GLP-1 receptor agonist therapy?
Yeah, we often talk about Thanksgiving. It's like, we all know about the Thanksgiving dinner where we eat, but then we overeat and we feel bloated. That's what many people with diabetes feel like when they have type 2 diabetes. And so when you have this return of satiety, we want to say, eat till you feel good. And that might mean that we have to eat slower. It might mean that we have to eat less. And maybe we'll come back in 20 minutes to the other half of that plate. But we'll just eat the first half first and then see how we're at. And I think people really like that full satiated feeling rather than the bloated feeling. So it turns that negative into a positive when they're doing mindful and slow eating. How about you?
I think that's good advice for everyone, whether they're taking these drugs or not. We have found also that eating more slowly, eating less, being mindful of how rapid the patient is eating, being mindful of how much, just tends to help them to manage these side effects and not feel them to the same degree, the same severity. What have you found is the most common reason that patients don't take the receptor agonists regularly or cause them to actually stop?
Yeah, so I think that there are maybe two separate things. I think some people have a pretty profound nauseousness or lack of appetite that is unpleasant. And, we'll work with them. And I think often you can work through that if the person does some of the dietary things that they will change. But some people just don't like that feeling. I think other things that I've seen is that if a patient has diarrhea longer than maybe 4 weeks on a longer acting GLP-1, that might be a reason that we stop therapy, because that becomes unpleasant over time. And the shorter acting GLP-1s tend to have more upper GI side effects, and the longer acting GLP-1s tend to have a little bit more lower GI side effects. So yeah, that would be the most common reason, albeit it's not very common.
So as we have been discussing, it's very important to individualize therapy for the patient, to address baseline gastrointestinal disorders before even starting the GLP-1 receptor agonist therapy. And gradual individualized dose escalation may help reduce the GI side effects. Titration is very, very important for helping patients to tolerate these drugs. And if the GI symptoms are persistent, then pausing the dose escalation to identify if there are any underlying disorders and manage them. Consider lower doses for those who are unable to tolerate the maintenance dose. And it's also okay to stop the GLP-1 receptor agonist, and then after the symptoms resolve, to consider initiating possibly a different drug within the group. So in conclusion, in addition to short-term therapy with the OTC anti-motility agent, and this should be short-term therapy, what do you recommend for managing our patients' type 2 diabetes and treatment-related side effects? Well, there are a number of different options. Let's remember that this patient has been on the 2 milligram dose for 3 weeks now, was a little concerned about diarrhea, since he hadn't had it previously during the dose titration. So continuing the current high-dose GLP-1 receptor agonist is likely to be a good option, considering the diarrhea tends to last usually no longer than 4 weeks, and especially if this is not a serious problem, maybe once or twice a day. At the 2 milligram dose is the optimal dose for maintenance and achievement of the goals. So if the patient is not too uncomfortable and can maintain the 2 milligram dose, then the recommendation is to reassess it at a later point. Dr. Schubert, do you have anything to add?
I think that's a really good approach to reassure the patient that these side effects are typically time limited. I just would highlight that I rarely end up using other agents like anti-motility agents. So if this is mild, I love the plan. If the person's having pretty severe or persistent diarrhea, or this is a great time for shared decision making, they're unhappy with it, you certainly could consider reducing the dose temporarily or even switching. But you've got up to the 2 milligram dose. So I think reducing the dose might be the best option if they're bothered with those side effects. But that's a good time to ask the patient and see what they want to do.
So for this patient, the patient was advised that the diarrhea typically resolves after the first 4 weeks of therapy. He was advised to stop the sports drink, as it can worsen diarrhea, and to avoid high fiber foods, juices that have a laxative effect, and dairy products while experiencing the diarrhea. The over-the-counter loperamide 4 milligram starting dose, then 2 milligrams is needed for loose stools. The package recommendation is no more than 8 doses in 24 hours. By week 5 of the high-dose weekly GLP-1 receptor agonist, the diarrhea had resolved and the patient was able to resume a normal diet.
So I have a clinical curveball. What if the patient is a 26-year-old female who complains of nausea and vomiting for 1 week after the dosage titration to a moderate dose of a once daily injectable GLP-1? So in addition to advising the patient to reduce meal size, which of the following might be helpful to manage the nausea and vomiting in this patient?
Stopping the GLP-1 receptor agonist until symptoms subside, and then considering a once weekly GLP-1 receptor agonist option might be the best approach for this patient. She opted to stop the daily GLP-1 receptor agonist and the symptoms resolved, and then start a GLP-1 receptor agonist. She was successfully titrated to the high-dose weekly GLP-1 receptor agonist. She experienced constipation followed by diarrhea during the dose titrations, but was able to manage the symptoms due to patient education, which was provided prior to and during the dose escalations. She has lost 12 pounds and her A1C was reduced by greater than 2%. She is happy with her progress. Key takeaways are nausea, vomiting, and diarrhea, and sometimes constipation, which is typically early in therapy and after dose escalation, are the most common side effects of GLP-1 receptor agonists. Educating patients about the benefits of therapy, explaining the potential side effects and the management strategies prior to therapy and during dose escalation can help patients to adhere to the therapy. And of course, as with everything, therapy should be tailored for the individual patient.